The provisional diagnosis is penile tendinopathy. The short-term goal is to stabilize the ankle from further damage and early immobilization. The outcome measure is to refer the patient to have an ultrasound scan to investigate swelling and inflammation and differentiate the penile disorders. Mid-term goal is to restore ankle range of motion and begins progressive rehabilitation exercise and gradually increase until restored to full activities. For the long-term goal management, strengthening ankle muscle tissue, including penile tendons, by performing proprioception exercise to avoid the recurrence of a lateral ankle sprain and penile disorder, tendon disorder. In outcome measure, Pisquella et al. 2016 state ultrasound scan provide a low-cost, radiation-free, and precise correlation between anatomic variance and clinical features in the penile disorder diagnosis. Lower extremity function scale can be used to determine an initial function and ongoing progress. A recent systematic review by Richard et al. Has demonstrated that proprioception is a measure of a neuromuscular response to sensory input. Therefore, proprioception exercise such as reaching test and star excursion balance tests are helpful to restrain or increase proprioception ability for reducing ankle. The management plan includes rehabilitation of injuries that are crucial in returning them to full participation and full functioning. Therefore, managing injuries should consider all types of injury, severity, healing time, type, and activity level of participation. The athletic foot type, biomechanic, and activity footwear, as well as external support such as bracing or tapping. During rehabilitation, the patient is to regain foot and ankle with the full range of motion, strength, and neuromuscular coordination. Isometric and open chain range of motion can be obtained in no weight bearing. Tower stretchings and rollerboard range of motion should be performed as a torrent. Hydrotherapy provides benefit in performance on range of motion, balance, and neuromuscular control exercise starting once weight bearing is tolerant. Increased strengthening exercise should be start once swelling and pain are controlled. Focus on dorsiflexion and plantarflexion strength. Resistant band and ankle weights are good to gain strength in all plane of motion. Functional rehabilitation exercise should begin with simple uniplantar exercise. The orthotic prescription include semi-rigid 3D print polypropylene for the shell material, standard MLA fill, standard heel cup height and heel cup width, standard shell width and the shell shape, barefoot posting bilateral NCSP 2-degree wireless with extrinsic EVA material, 4-foot valgus extension wedge to redistribute 4-foot pressure, 2 mm in black color EVA for the full cover with 1.6 mm coron for the cushioning. Add lateral flange and extra keyboard notch to enhance the lateral support. Use semi-rigid 3D print polypropylene to partially control the abnormal position of foot during gait and provide flexibility during running sport activities. Michael and Colin 2014 describe semi-digit orthosis offering short absorption and flexibility to support and stabilize deformity and relieve the pressure by weight transfer. The posting of a barefoot is done by extrinsic the NCSP bilateral 2-degree, which means the posting will be correct 4 degrees on the left foot and 2 degrees on the right foot. Over than 4 degrees, correction may be cause too much invitation if the patient with a low tolerance. Use a 4-foot valgus wedge to provide pronation force on the forefoot, as the patient has a 4-degree valgus alignment in the forefoot, and as well as to improve palpation. Wood et al. 1977 state the functional orthosis for non-rigid 4-foot valgus deformity can limit the subtalar joint pronations. Applies full length or 2 mm EVA top cover to the footwear size, which allow trimming. Add extra cushioning with a 1.6 mm layer of poron for shock absorption when patient performs sport activities. Use a keyboard notch and lateral flange to support a lateral column. Lateral flange will resist abduction and may invert the foot, which help to limit the lateral ankle sprains. Gosser et al. Study in 1999 states that keyboard notch is applied on the orthosis can provide a mechanical advantage of the peroneal longus to stabilize the first way. The junction therapy and footwear advice, including protection, eyes, rest, compression, evaluation, and avoid activities such as changing direction or cutting. Non-steroidal anti-inflammation medication to decrease pain and inflammation for the acute phase of injury. Early immobilization with a controlled ankle motion boots or cast for 4 to 6 weeks is recommended. Immediately start range of motion exercise, calf stretching. Initiate strengthening of a foot and ankle with isometric TheraBand for 4 ways ankle strength exercise, close chain exercise when pain level can be tolerant by the patient. Strengthen peroneal tendons with a foot eversion exercise. Begin a basic level of proprioception exercise from even ground surface, progress to uneven ground surface. Initial cardiovascular exercise such as walking, biking, or swimming. Wear an ankle brace or strapping when perform tennis training. Tissue massage to reduce tension in peroneal muscles. Restore full pain-free range of motion in weight bearing. Educate patients with appropriate footwear for tennis training and peroneal tendon dysfunction can cause lateral ankle pain. Refer patient to specialists if the injury is severe, such as a orthopedic surgery, sport medicine, physicians for the rehabilitation care. Treatment start with a conservative measure, including protection, relative rest, ice compression, evaluation, medication, and rehabilitation exercise. Intrinsic strength training will involve active muscle lengthening. This therapy helps to promote a new collagen formation. O'Neill article in 2015 has proved beneficial for eccentric exercise in the treatment of tendinopathy. The eccentric factor involve tendon injury, including wearing inappropriate footwear for sport activities that poorly control motion, cushion, and stability. Owen 2014 demonstrated the positive effect of wearing orthotics to help unload, reinforce, and protect the tendons. Therefore, orthotics act as an intervention option for the long-term management to treat functional ankle instability, allow the patient to remain physically active, and improve the overall stabilize and proprioception. 2015 systematic review on ankle sprain amongst the sporting populations conclude that proprioception training programs are effective at reduce the rate of injury recurrence, particularly in relation to an ankle sprain. The management plan costing is total $1,015, including 6 times appointment for podiatric care. They cost $315 after private funds rebate. X-ray is free. Ultrasound costs $50. Cam boots cost $100. Orthosis for $300 after private fund rebate for $550. Ankle brace for $100. Tennis footwear $150. The total is $1,015. Patient undertakes 6 weeks of podiatric care. The second appointment will be 1 week after initial treatment. Every 2 weeks for the follow-up until fully return to normal sport activities. Ultrasound is in low-cost dynamic examination to provide evaluation of tendon in motion and so the area of tendinosis. Short leg cam boots for early foot and ankle immobilization to protect injured tendon. The ankle brace help to reduce swelling, improve circulation, provide stabilization of the ankle, and protect ankle from risk of a sprain during physical activities. A pair of a high-performance tennis footwear with adequate support cushioning and a good amount of grip on the sole for the running on the court. Lastly, a pair of a custom-made orthotics with a modification to patient's foot type and insert a heel wedges for a provide better support of the lateral column. This is the end of my presentation. Thank you.